thank you very much for that introduction. And again, it's a real pleasure to be here in this beautiful country. I'd like to know how many of you are familiar, have seen ACE, because it is translated into Turkish. Could you put your hands up if you're familiar with it, if you know of it or seen it? I can only see 2 hands. No one else? Oh, okay. So, why did I develop it? I developed it because I think we need to have real good semi-structured interviews that are comprehensive. Because clinicians, you know, we can get a bit lazy sometimes. We go through things and we forget things. And, you know, we forget to be as comprehensive as we need to be sometimes. So, with working with adults with ADHD, a very useful semi-structured interview was developed called the DIVA, and some of you will know about that already. But there was nothing for children. It was quite astonishing, really. And so I decided to develop something for children. And then from that, it made sense also to do an adult version. It's slightly different to the DIVA. It takes a slightly different perspective. They're not in competition with each other. You just use whichever one you prefer. Like the same with rating scales. There are many different rating scales for ADHD, and people use the one that they like. Well, I think it was very necessary to develop it because ADHD is highly prevalent. There's a worldwide prevalence of ADHD of around 5%. It's a chronic psychiatric behavioural disorder that is characterised by a persistent pattern of symptoms of inattention, hyperactivity, impulsivity, and they're persistent across different contexts. The behaviour of people with this condition is more frequent and more severe than that's seen in individuals at the same developmental level. And they actually have a form of impairment. It impairs their functioning in some way. Usually, diagnostically, more males are diagnosed than females, with a ratio of about 3 to 1. And I think that's because males are more likely to be referred, boys are more likely to be referred than females, because they're very hyperactive, they're disruptive, their behaviours. As many of you will know, a boy child with ADHD will be rolling around the floor in your clinical room. They'll be under the table, sticking their fingers in plug sockets. You know, they have a behavioural presentation that causes them to be referred. Females, by contrast, perhaps don't present in quite the same way. They may be more inattentive, they may daydream, they switch off more. And so they're seen as not having such a problem. So I think that's probably why there is a difference in the ratio of males to females who are referred for assessment. What is ADHD not? It's important to know what it is. It's also important to know what it's not. Well, it's not a learned behaviour. It's the behavioural presentation. It's something that's observable. So it's not a learned behaviour. It's not a learning difficulty that causes problems with learning. It's not because the child is disobedient. They're not disobedient, bad children. And it's not because parents are bad parents. Positive parenting can help manage the challenging behaviours, and many parents really struggle to raise children with ADHD because they can be very difficult to manage. They're challenging, and people get very exhausted and tired with a very challenging child all the time. It's also, though, not an attachment disorder. But it does, though, impact on attachments and relationships. Well, there are two diagnostic classifications that are used to diagnose ADHD. One is the DSM-5 and the other is ICD-10. ICD-10 is the one that's used more in Europe, and DSM-5 originated from North America. But I think in common use, most commonly, DSM-5 is the one that's used, more so than ICD-10. And I think that's because it catches more people with ADHD, with these kind of problems. ICD-10 identifies children with a very severe form that we call hyperkinesis. So for DSM, you have to have at least 6 symptoms from any of the domains. It has to be present by age 12, and it can be present with comorbid conditions. And now DSM-5 acknowledged that it can be present with autistic spectrum disorder, which was something that we didn't have before, that they didn't consider before. With ICD-10, though, it has to be present before the age of 6, and it's not, you can't define it with comorbid conditions. They don't acknowledge comorbid conditions. And that's a problem, because I think many of us know that there's no such thing really. It's very rare to have just ADHD. I think it's something like 96% of kids with ADHD will have something else as well as ADHD. So there are typical presentations at different ages. So, you know, you can see these presentations even from preschool. I've heard of children who have been asked to leave the kindergarten or the nursery because they're just very, very disruptive. They're overactive. They may be described as a complete whirlwind, or impulsive. They're not listening to what people are saying. There's no kind of sense of danger. In primary school, they may be, they can do longer activities, they can do brief activities, but they change the activity very frequently. They can be very forgetful. They're restless when they're expected to be calm, and they may act out of turn. They kind of interrupt, blurt out, and there's thoughtless, rule-breaking behaviour. As they move into adolescence, then, they can perhaps focus for a bit longer. So they might be able to focus for, 30 minutes, but they may lack focus on details, and they don't plan very well. They have very poor planning. In fact, some of the research that I did with adolescent females with ADHD, we found that they don't plan at all. If you ask them what their goals were in life, they were just like leaves in the wind. They had no real idea of the direction they were going, or even where they wanted to go. They might be fidgety. They're more fidgety than perhaps overactive, and they have poor self-control. And in adolescence, I think that some of the recklessness and the risk-taking may really start to come to play. In adulthood, then this is where you have some problems with they're always late, they forget appointments, they don't think about things or plan things in advance. One of the big problems is that they never write things down. They don't use diaries. When I'm working psychologically with people with ADHD, I'm always first thing I do is tell them to get a book and bring a little book, and that's going to be their sort of ADHD treatment book, and I get them to make notes in it and write things down. They may have a more subjective sense of restlessness. They're not hyperactive. You don't have like an adult rolling about the floor in your therapy room or in your consulting room and sticking his fingers in plug sockets. Impulsivity is a risk there in adults with sort of accidents, like motor accidents, road rage, not making good decisions. So there are some very typical presentations at different ages. And these are the kind of things that you'll see happening in terms of the developmental impact of ADHD, starting, like with, there are social problems, behavioural disturbance, and then sleep problems, and then as they grow up a bit older, peer rejection, academic problems, mood instability, antisocial behaviour, relationship problems continue. Comorbidities really start to come into play as they get a bit older, a lot more comorbidity. And then moving as they get much older, you've got motor accidents, alcohol, drug abuse, marital discord, social difficulties. So if we think about comorbidity, if we look at comorbidity and look at this from age 6, then when they're a bit older as children, and then into adolescence, and then becoming adults, you can see that when they're very little, the oppositional defiance is much more common, is quite common. And then as they grow up, that's still common, and then that starts to, improve as they become adolescents and adults. But more things start, but what you get then is you'll get conduct disorder taking over, and that might continue. And for some, but just under a third, they'll have develop an antisocial personality disorder. Young children might have communication problems, but then this is a comorbid presentation that becomes less frequently observed as they grow up. But anxiety starts to really pick up, starting in children and then becoming quite common. Same with depression and dysthymia. Substance use disorder, of course, isn't very rarely diagnosed in children, but can be very commonly diagnosed as they become adults. ADHD crosses cultures. It's seen in children's play, in different cultures, in schools, in different cultures. It's seen at home, and it's seen in occupation as they grow up. It's across cultures. So what might trigger a screening assessment? What do we need to be thinking about that you should start? What kind of things will trigger it? Well, it could be lots of things that are triggering it. So it could be breaking rules, it could be a lot of disruptive behaviour, being excluded from school. A lot of kids are excluded from school. And in fact, I was part of a group in Europe that lobbied Parliament, the European Parliament, to say that at the second fixed-term exclusion from school, that should trigger some kind of assessment, some kind of more in-depth assessment, because that's an indication that there is something going wrong when a child has been excluded from school. Maybe not the first time, because children can learn, but the second fixed-term exclusion, that should trigger somebody somewhere to think we need to look a bit closer at this child. Maybe struggling across different contexts, damaging property, contact with the police, conflicts, lots of conflicts with others, school problems, bullying. There's lots and lots of things that might cause someone to be concerned about a child and to think about, we need to be doing something about this. And what should then that assessment look like? It should be, that assessment should be comprehensive. So, best practice, you'd be including a clinical interview, you might include some rating scales, you might go and observe the child, have some kind of school observation. There might be a psychology input, medical input, of course, and you might also be looking for supporting information across contexts. Ironically, I don't know what it's like here in Turkey, but sometimes with teachers, we find that in the UK, I've heard many times that teachers can be quite disparaging about ADHD. They might say, well, we don't believe in ADHD. I've taught many children, and this child hasn't got ADHD. This isn't ADHD. This is because this child, is nothing like, say, a female. It's nothing like the children I've seen before with ADHD. And I remember having a conversation. I was doing an assessment for court, actually, for a brother and a sister. And it was actually the teachers that were causing all sorts of difficulties and problems with this, because they were saying that the boy has ADHD and not the girl. So I went and I interviewed these teachers, and I said, okay. I said, no, we know what ADHD is, Dr. Young, and you know, this is all rubbish. It's not going to be helped to put these children on medication for this and stigmatise them in this way. I said, okay. So what is ADHD? You tell me what ADHD is. And they looked at each other and they said, well, it's ADHD. I said, yes, but what is ADHD? What do you see? Oh, an attention deficit. I said, right, okay. Anything else? Hyperactivity. I said, well, yes, well, it's called attention deficit hyperactive disorder. So, yes, what else? And they couldn't tell me anything else. They couldn't tell me anything about impulsivity or any other problems. So, the clinical diagnostic assessment needs to assess the core symptoms of ADHD and associated problems. You need to think about these symptoms in different contexts, across different contexts. You need to know the origin and the developmental course of the symptoms. When did they start? How you know, and why? Do you think that they started? Was there something else going on, you know, in that child's life at the time? You need to compare those symptoms with what you would expect at that developmental level. And you need to be thinking of the presence of other physical, mental health or learning problems. You need to put it in a context. Associated problems, as I said, you don't just have ADHD, you have ADHD plus lots and lots and lots and lots of other things. All these associated problems need to be recognised and treated, but you don't diagnose on the basis of that. You don't diagnose because someone's just got, you know, a learning problem. You wouldn't diagnose someone with ADHD just because of that. So what are the differential diagnoses? If it's ADHD, what other things do you have to have in your head? Well, you have to have, you know, specific and global learning disorders. You need to be thinking about neurological disorders, disorders of motor control, Tourette's, bipolar disorder, anxiety disorders, depression, autistic spectrum disorders, conduct and oppositional disorders, borderline and antisocial personality disorders, hearing impairment. Can cause attentional problems, and other congenital disorders. It's like a checklist in your head, and the task is to think, is it this? Is this the differential diagnosis, or is this a comorbid diagnosis? And you have to work that out. The NICE guidelines said, well, drug treatment for children, young people and adults with ADHD should always form part of a comprehensive treatment plan that includes psychological behavioural interventions and educational advice. So we're looking at this we need to be looking at this in a very holistic way. What are these interventions? Well, for children, there are parenting programs to shape behaviour and to teach them to foster positive relationships. There's cognitive behavioural therapy. Perhaps you would do that more with adolescents, and to help them to think and cope by addressing their thoughts, their feelings and their behaviours. There's classroom management techniques that can be discussed with teachers to reduce the impact of ADHD on learning by adapting teaching and environmental factors. Their social skills training may be needed to address related social needs, and cognitive behavioural therapy for adolescents and adults. You're working much more directly with the adolescents and adults than you would be with the children. You might be working more indirectly with children because the intervention might be focused on changing the environment around them, so changing the environment in school or in home by working with teachers and parents. CBT is something that actually I think that you can do with children. you see that a lot of ADHD kids, as I just said, your intervention is with others, is through others. But I've often thought to myself, why can we not intervene directly with the child? Why don't we do that? If a child has got an anxiety disorder, you don't intervene for the anxiety disorder through the parents. You know, so why are we not doing that as well with ADHD? And I think that we should be. The aim is for the child to develop skills in behavioural control, emotional control. They need to, as they get older, they need to take responsibility for organisation and to manage their time. They need to improve their attention and memory skills. They need to address social skills, and they need to be able to manage comorbidities. And there are CBT, really excellent CBT interventions that can be done that can achieve that. And these are, if you're interested, these are 2 books that I've got coming out this year that are about intervening directly. Well, they're 3 books. This is the STAR, becoming a STAR detective. This is about developing skilled thinking and reasoning. And there's a facilitator's manual and a little book for the kids as well. This one is a book about helping children with ADHD, and it's a program working with junior school children, same as this one, up to about age 12. And it gives advice for teachers and parents so that they can actually deliver the program as well. They're both out in May. These are 2 adult programs that I've worked on. One is, they're both CBT based, one's a group program, and the other is, they're both for adolescents and adults, and the other is an individual program. So we have good interventions, and we all know about medication as well. But, you know, why do we need to be better at diagnosing ADHD in children, young people and adults? Why do we need that? Well, this is why. This is the long-term outcome of childhood ADHD. Even when they're treated, the long-term outcome can be pretty bleak. I often feel that they're just lining up, queuing up to hit adolescence, especially when they disengage with services, don't transition to adult services very well, and they just fall off the cliff. They start to misuse substances. This is some data from a prison population that we looked at why they are abusing substances. We wanted to look at the pathway into using substances. What motivated them to start using substances in the first place? What motivated them to maintain the use of that drug? What was the reason they then transitioned to use other substances? And what was the reason that they maintained using other substances? So they were like 4 basic kind of questions. And in the analysis, this has just been published in Dual Diagnosis last week. And in the analysis, people who abuse, if you know, anyone who abuses substances, it was all, there wasn't any clear motivation for starting. It was a lot of sensation seeking, a lot of, you know, and the reasons for maintaining was all dependency. If you had conduct disorder, it was kind of similar actually. It was sensation seeking that started and accepting drugs as a culture, and then dependency. If you've got ADHD, your pattern was completely different. They were clearly taking substances to cope. They maintained to cope. They transitioned to another substance to cope. They maintained to cope. And by this stage, of course, there's dependency kicking in as being addictive substances. Coping, that's another word, I think, for self-medicating. Some more data from Dalsgaard et al. That showed ADHD is actually a deadly disorder. Data from the Danish National Register followed up just under 2 million people. 32,000 of them had ADHD. And they basically found that if you have ADHD, you have a much greater risk of dying younger. Why? The most common death was accidental death. And in fact, it was 78% of the deaths were unnatural deaths. The mortality rate as well was higher in females than males. That's really shocking, isn't it? That really makes us sit up and think we absolutely have to be identifying and diagnosing young people with ADHD. And how do we do that? Well, I'm thinking to myself, well, we need better assessments. We need a more comprehensive assessment. We can't just do it as hit and miss. It's too hit and miss just to do everything, a checklist in our head. How much does untreated ADHD cost? Well, against the Danes, they've been doing fantastic research in this because they have these huge national registers. They have data on everybody there. And they can match up all the registers. And basically, they found that the aggregate cost of ADHD, by the time they're for individuals who are diagnosed as adults, compared to the general population, they were costing around £343 million more than the general population. And if you look, you could say, well, maybe that's a family issue, it's not ADHD. So they compared them to their siblings and found that they're still costing £265 million more than their siblings. The societal costs were costs that they looked at that were associated with an individual, with family, and also to local government. Those kind of costs include things like income loss, income support, costs of crime, cost of victims, cost of social services, education, healthcare, and foster care. What they found was that more than half of these costs were paid by the public sector, paid by the government, some kind of government funding. And the main contributor was due to low labour market attachment. In other words, they can't get a job, so they're supported by the state, and all the costs associated with that. Again, really shocking. So if people don't want to do it, don't want to assess and diagnose ADHD because they're dying quickly, or if they don't want to assess and diagnose ADHD because they don't want people to live healthy, productive lives and have life satisfaction, if they don't care about that, maybe they'll care about this. It's costing them money in their pocket in taxes. What that really means is the cost of undiagnosed ADHD is all the time people have, days off work, days off school, parent and carer who have to have time off work to care for children who are unwell or sick, the cost of being in prison, costs of court, the court costs, prison costs, police custody costs, all the treatment of mental health disorders and treatments, the misdiagnoses, because they're presenting over and over and over again, road traffic costs, not being productive at work, support at work, the educational problems, it takes them, some people, I've known many people to sit a 3-year degree and it's taken them 5 years to get it. So it's fairly obvious that we need to define impairment. We need to consider what is impairment. You have to have functional impairment with ADHD. You had to be impaired to a degree that some kind of intervention is advised. And without that intervention, there's likely to be long-term adverse implications. So the problem must be pervasive. It must be at least moderate in severity, and it must occur in multiple settings. It must have significant impact across multiple symptom domains. So this is an example. The red are psychosocial impairments, such as driving accidents, behavioural problems, educational problems, not coping well with things, social relationships, occupational problems. Clinical are sleep problems, low self-esteem, impairment in terms of their emotional lability and the risk for comorbid disorders, distress from symptoms, and neurodevelopmental, of course, are the cognitive impairments. Now you're beginning to wonder, I expect, well, when's she going to start to talk about ACE? But I think it's really important to frame this as to why I thought it was important to develop ACE and to have a comprehensive clinical assessment, a comprehensive, semi-structured interview that prompts you to do a really great job, that prompts people to be even better clinicians, to move from being not just good clinicians but excellent, so you capture the people. It's a tool that was designed to support healthcare practitioners. I mean, clinical decision-making has to be the clinicians at the end of the day, but it provides guidance in diagnosing ADHD in children between the age of 5 to 16. It assesses the extent to which core symptoms are impairing. The symptoms don't just have to be there, it's are they impairing? And I think that's what we get with lots of high-functioning people with ADHD. Maybe they have the symptoms, but they develop strategies to manage the symptoms so they don't have the associated impairment. And usually what I find with adults who are high-functioning, and I've had many doctors with ADHD. At the moment, I'm treating a surgeon with ADHD. But they're okay until things go wrong in their lives. And it's like a whole load of cards. Everything falls over and all the symptoms come and they struggle. ACE will also prompt you to investigate and consider the symptoms in both home and school situations. So, what's ACE Plus? ACE is for children, ACE Plus is for adults. And again, it's similar. It's a semi-structured interview. It's a tool designed to support you in making these assessments in young people from age 16 and above. ACE Plus prompts you to assess core symptoms of ADHD in childhood and in adulthood, because you're doing it now with an adult, but you have to still assess what happened to them in childhood. It also prompts you to, again, consider impairment. How much have they been impaired and are they being impaired now? To consider different settings, home, occupational, social. And occupational settings are defined as all occupational activities outside of the home. So if somebody's not working, that doesn't matter, because they could be in paid work, they could be in voluntary work, but they could also be, you'd also assess outside of the home activities that involve sports and social activities. ACE is available in Turkish. It was translated by Bengi and her team, and it's available. You can download it for free from my website. It's also in all these other languages, and it's just come on in a couple more, actually. So this is ACE. This is what the cover looks like. It's assessed ADHD in children via a family member. So you get a family member report, who's usually a parent or a carer. But it has to be someone who's known the child for a considerable time. That informant must be familiar with the child's functioning in different settings. The child may also be invited to contribute to the interview to give their perspective, and I think that's really important. I think sometimes that just doesn't happen. Wherever possible, it will prompt you as well to obtain independent information, such as school reports, to corroborate the interview. So it begins with a section that covers background information that you need on the child. They then follow the symptoms relating to inattention. There's 9 inattention items. There's the hyperactivity items and impulsivity. The clinician's encouraged to use motivational language and elicit detailed responses from the individual. And you have to judge whether a symptom is present and if it's impairing. It's not enough just to be present. So in the background information, you'll collect demographic information, information about family background. Early risk factors. It will prompt you to think about the early risk factors, such as whether there was a premature birth, whether the child had a low birth weight. Was there any form of early trauma? Was any head injury or that problem like that present as a child? Were there prenatal mental health issues in the mother? What about smoking with the mother, or any substance misuse during pregnancy? So it prompts you to consider systematically the early risk factors that might be present. It prompts you to take a medical history, but also an educational history. It prompts you to consider the quality of the child's peer relationships and relationships in the home. And then you move on to the actual symptom ratings. And you need to consider the onset. When did this symptom first appear? Because they must be present before age 7 or before age 12, depending on whether you're using ICD-10 or DSM. They have to be present for 6 months or more. They have to appear in more than one context, and they must occur more frequently than typically expected at the child's age. So there are 9 inattention criteria, and for these the child must find it difficult to pay attention to details. They might make careless mistakes. They might present with difficulties in maintaining attention and not listen when being spoken to directly. As such, they're easily distracted or forgetful. They may avoid or dislike sustained mental effort and have trouble completing or organising tasks. They may also lose or misplace things. So this is what it would look like. So you have here, this is the first symptom, and the question here is, does the child often fail to give close attention to details or make careless mistakes? That's the first one, and then it prompts you to consider this at home, and then again to consider it in school. So it prompts you to consider those things. There's a space here to make notes. Here and here, there are brief descriptions to guide the clinician in assessing the symptoms. You don't read that out, it's just to guide the clinician for what you need to be looking for. It's not a checklist, but it's important to consider if a symptom's present, for how long, and whether there's associated impairment. You can make notes in the box, and then you have to decide, is this symptom present or absent? And you decide with that based on what you noted. So the descriptions, the descriptions above the box. At home, it says, right, at home the child may complete tasks inefficiently. For example, they may miss out steps in chores or other activities which then need repeating. They may not pay attention to instructions or break items due to rushing, because they're not paying attention to what they're doing. The child may make lots of mistakes in their homework, even when they understand what to do, and homework may be presented as messy with lots of corrections. The child may not notice important information in the environment, such as road crossings or signs of danger. So that's the prompt that you have to read to give you ideas to start and say, well, tell me about how this child doesn't pay attention to things. What are the problems? What happens at home? The prompt in school is that in school the child may hand in incomplete work and or poorly presented work that looks rushed and contains many errors. On test papers, children may skip questions, and they may not check whether there are more questions on the other side of the paper. They don't turn it over, leading the child to achieve a lower mark or grade. Children may find tasks that require a lot of detail particularly stressful and time-consuming. So these are the prompts that you have in front of you to complete. These are the prompts you see that are here to complete this. So an example would be a child called Casey who isn't listening to her parents when they ask her to do work around the house or tidy her room. She finds it hard because there's a television in her room and she often ends up watching that instead. If she does tidy things, she forgets where she's put the things after a while. She finds it hard to concentrate in class because she's easily distracted and rarely completes tasks on time. She often complains that tasks take too long, and she absolutely hates having to concentrate for the whole lesson. She really struggles. So that's the kind of thing that you might have notes on. With hyperactivity, there's 6 criteria by which hyperactivity is assessed. The child's often restless, might fidget or squirm. The child might leave their seat when they're not supposed to. In essence, they're always on the go. The restlessness may also be seen verbally, so they might find it difficult to engage in activities quietly, or they might talk excessively, even if they've been asked not to. So, an example of this one, so the symptom may be, does the child often fidget with their hands or feet, or squirm on their seat? At home, the child may be observed to be fidgety, restless, even when watching television, at the dinner table and or in the car. The child may fidget even when engaged on a task or activity they find interesting, or when feeling tired. They're frequently being told to stop rocking back on the chair, kicking their legs, or fiddling with objects. These behaviours may cause problems in the cinema, in church, or in restaurants. Now, you see how that last bit is guiding you to think about impairment. Is the symptom present, and how is it impairing? Can you take the child to the cinema? Or does it mean that child can't go to the cinema? Can the child go to church? Will they behave? In school, teachers may comment that the child is fidgety and restless in class, irrespective of the topic or activity, and that their fidgeting disturbs other children. The child may shuffle about in their seat, kick their legs, rock back on the chair, fiddle with items on the table, or doodle on books. The child may be perceived as clumsy because they often fall over and knock over items. So, when completing your notes, an example here could be something like in the home box you might have, Robbie is very hyperactive. He runs around the house, he makes a lot of noise. The family have had to stop sitting together at the table for dinner because Robbie's too disruptive and fidgets with his hands and feet constantly. So it means they can't sit and have dinner together as a family. In school, he finds it hard to sit still. In class, he won't sit for more than 5 minutes before standing up and disturbs the other children in class. He also talks loudly during silent reading periods, so he won't settle. Impulsivity, there are 3 criteria which assess impulsivity. And the child might lack patience now, meaning that they find it difficult to wait their turn. This can be in conversation. They might not wait for the other person to finish before they respond, or behaviourally, because they might find it difficult to wait in line. They might be intrusive and interrupt others when they're busy. So, a symptom, for example, does the child or often blurt out answers before questions have been completed? All of these symptoms, by the way, you're asking whether something happens often. You're considering frequency. So at home, the child may have difficulty waiting for their turn to speak, and instead they blurt things out or interrupt others. They struggle to follow the turn-taking rules of conversation, but instead they're motivated to say immediately what is on their mind, even if this is unrelated to the topic of conversation. They get into trouble because they're blurting things out all the time. The child may be impatient for others to finish speaking. Older children may finish other people's sentences for them. In school, the child may be frequently reminded or reprimanded for talking in lessons. The child may seem to dominate the class by frequently calling out or talking over others. The child may have difficulty waiting for their turn to speak and answer questions. Older children may have some awareness of this difficulty, but struggle to inhibit their behaviour. These behaviours may irritate peers and lead the child to be popular. Now, a child with ADHD isn't going to have all of this, necessarily. They might do, but they might not. They might just have some of it. So it's for you, these are just prompts, really, for you to be thinking about the kind of things you need to be looking for when you're talking to the parent. So, what might go in the boxes here would be at home. Lewis's mum says there's no break in his behaviour. There's no stop. There isn't like a brake like in a car. He says and does things that upset or hurt people. He often does this without thinking of the consequences. At school, Lewis shouts out answers, interrupts others when they're talking in class. He plays for the school football team, and they regularly practice drills in which the players take it in turns each to take a penalty. Lewis is generally disruptive and finds it difficult to wait his turn, often in pushing in front of others to take the penalty. There then follows an observation section, and this is an observation where you make notes about things, that you've observed, things that you've noticed during the assessment. Or you could also make notes there if you do a formal observation in another setting. Then, with the adult version, this is where ACE differs very much to other semi-structured interviews, because it's not just about ADHD. There are prompts then for you to then consider comorbidity and a differential diagnosis. Now, it's important to note that it's a clinical screen for these conditions. It's not a diagnostic guide. So the assessor considers common differential and coexisting conditions, and you have to decide whether they're primary, in which case it would be a differential diagnosis maybe, or secondary, in which case they're comorbid or coexisting. It's recommended that you don't actually disclose the condition being discussed. You don't want alarmed parents to walk out because, it's just a screen. It's just prompting you to consider other things. So the assessor should lead with general questions that relate to the condition before you focus on specific symptoms. Bear in mind, though, that if somebody is applying the ICD-10 criteria, that classification system does not recognise comorbid conditions with ADHD. So this is an example of what it would look like, comorbid and comorbid problems and disorders. And it has some brief information for you. And then it starts with a disorder that's mentioned here. You make qualitative notes, you can put notes in the box, and you have to decide whether there's a box here to say whether it's been previously diagnosed. Sometimes you know that the children have a diagnosis of X, Y, and Z. So have they been previously diagnosed with it? And if you think maybe they might have it or have a comorbid condition, you need to say whether you think further investigation is required or not. So it's just a prompt. So you have to decide whether it's present, a known diagnosis, whether it's absent or possible. If you think more information and more investigation is needed, you mark it as possible. And these are the ones that it prompts you to consider. Autistic spectrum disorder, and it gives you a suggestion like, is there evidence of speech delay, problems with forming and maintaining social relationships, social communication, rigidity, repetitive behaviours, and sensory hypersensitivity. Another one is cognitive impairment. Is there evidence of generalised or specific learning difficulties, such as reading, writing, or arithmetic difficulties? Is there evidence of tic disorder? Is there evidence of motor or vocal tics? Depression. Is there evidence of low mood, negative thinking, low self-esteem, fluctuating mood, and irritability? And important to note whether there's ever been suicidal ideation or behaviour. Disruptive mood dysregulation disorder. Is there evidence of excessive irritability and or anger, either in intensity, frequency, and or ease of provocation? Post-traumatic stress disorder. Has the child experienced any significant physical, sexual, or emotional trauma? I mean, I have to tell you that I did a lot of consulting with medical colleagues who are absolute leading world leaders in ADHD. People like Eric Taylor, David Coghill. In fact, I was at the World Congress of ADHD a few years ago, and I had my ACE already, and I was sort of stalking them, trying to go and have coffee with them to say, can I just show you this? I wanted to make sure that it would work in different countries, and also that it was really comprehensive. Another condition is traumatic brain injury. It prompts you to consider if there's evidence of a history of severe head trauma or recurrent head injuries, such as because of falls, sports accidents or motor vehicle related injuries. And here you also need to note whether there's ever been any loss of consciousness. Of course, the disruptive behavioural disorders, you consider oppositional defiance disorder and conduct disorder. Is there evidence of oppositional behaviour or refusal to comply with authority or more serious antisocial behaviours? You'll think about speech and language impairment. Is there evidence of specific expressive and receptive language delay? Interpersonal problems are here as well. Is there evidence of peer relationship problems, mixing with much younger or older children and or disrupted relationships with teachers or other adults? Anxiety disorders. Is there evidence of phobia, panic, separation or generalized anxiety? Obsessive-compulsive disorder. Is there evidence of obsessions, compulsions or other ritualistic or stereotyped behaviour? And then, more generally, with other developmental disorders, is there evidence of gross motor or fine motor developmental disorders? Substance misuse, quite a lot of comorbidities when you put them all together. Is there evidence of the child using or misusing substances, including alcohol, cigarettes, prescription medication, or illicit drugs? So many times we forget about misuse of prescribed medication that kids might access from the bathroom cabinet. Other physical conditions. So does the child have any other diagnosis or suspected inherited or acquired conditions, such as hearing impairment, sleep apnea, nutritional deficiency, obesity, fetal alcohol syndrome. Fetal alcohol syndrome is something else I think that's often missed, and genetic, metabolic or endocrine disorders. And then general other mental health. So does the child have any other mental health problems, such as eating disorder, bipolar disorder, psychosis? Remember, it goes up to age 16. So then you get to the point where you are scoring, and of course the disorder is devised to be assessed clinically and to use clinical judgment. So it was quite a challenge actually to put this into an algorithm, because at the end of the day there always has to be some form of clinical judgment involved. But through a lot of discussions with a lot of experts, including Xavier Castellanos, who was the person who led the DSM-5 working panel, was on the DSM-5 working panel. You copy over the symptom domains for inattention, those that you've decided are present, so you tick and then you just total, and you do the same here. And then it guides you to consider whether you've got how many symptoms, whether you've got 6 or more, yes or no, same here. Then it takes you through some questions, so you decide whether the symptoms are present. And then it's prompting you to say, but are they found in more than one setting? So were they found in different settings? Were they present before the age of 12? Have they been present for 6 or more months? Are the symptoms impairing the child's functioning and development? Are these symptoms better explained by another condition? And then from that, it will give you the diagnosis, predominantly inattentive or predominantly hyperactive or combined. Similarly, if you choose to do it the ICD route, it's a similar thing, but of course these separate the 3 out. Inattention, because now because in DSM, hyperactive impulsive domain is together. ICD separates each out, so you have to consider 3 now. And then you ask the questions again. So ACE Plus is administered directly to the interviewee. So it's helpful to have an informant, of course, and corroborative information should be gathered from someone who knows the interviewee well. Or also we often look for independent information, if you can, to get school reports or occupational reports. And it can be hard for the person to think back to their childhood, so any childhood reports should supplement the account where appropriate. It's very helpful to have that. If ACE has been previously completed in childhood, or they've been previously diagnosed in childhood, but they're presenting for an assessment for some reason now, it's not necessary to repeat the child sections of ACE+. They're there in case you're assessing an adult who's never been assessed for ADHD or never had a diagnosis of ADHD in the past. So what this prompts you here to do is to say, yes, they did ACE, and they did it on these days, this date, and they got a diagnosis. Or you tick this box to say the interviewee has a documented diagnosis of AD as a child, and then it's asking you to detail that in the box, to put where you found that, how you know that, who did it, and what have you. So it targets and assesses the same 3 symptoms: inattention, hyperactivity, and impulsivity. And it guides the clinician to assess the domains in much the same way. If the person wasn't clinically diagnosed in childhood, then you have to, though, consider how these symptoms manifested across childhood as well as adulthood, and how they present at home, educational and occupational environments. So this is what ACE Plus would look like. So it's very similar, like as you've got home activities and here occupational activities. So home, you prompt to consider how it's expressed at home and in their occupation. Again, there's a brief description here and here to guide the clinician in assessing the symptoms. You do not read that out to them. It's just your guide for you. You have to consider whether the symptom is present and for how long, and whether it's impairing. And you need to also consider whether the symptom was present in childhood. So you start with, is this symptom present in adulthood? And was this symptom present in childhood? And it's the same here, adulthood and childhood. You make qualitative notes in the boxes, and once you've made your decision, you'll go up here. So this is childhood, was it present in childhood? And adulthood, was it present in adulthood? Does it the same way, exactly the same way as we do with ACE. So the adult finds it difficult to pay attention to details, they make careless mistakes, they present with difficulties in maintaining attention, they don't listen, they may be distracted or forgetful, they avoid and dislike sustained mental effort and have trouble organising and completing tasks. They may also lose or misplace things. So, an example of the question, do you often fail to give close attention to details or make careless errors? With the adult, you'll be thinking, well, at home, this person may complete tasks inefficiently. They may not pay attention to instructions and miss out steps in chores, leading to household items being assembled incorrectly. Great one is when you buy the flat pack furniture, and they've got to put it all together and follow the instructions. And they make careless mistakes and become very stressed over making errors. As a child, they may have avoided doing homework and made lots of careless mistakes in their homework. They paid insufficient attention to road signs or signs of danger. So in occupational settings, the prompt here is going to be, work is poorly presented, it seems rushed and contains errors. They may compensate at work by applying an overly rigid routine. And that means they may appear as perfectionists, but they need a lot of time to complete tasks. They find tasks that require a lot of detail particularly stressful and time-consuming, and avoid administrative difficulties which they find tedious. As a child, in examinations or when completing test papers, they skipped questions and didn't check their work, leading to lower marks and grades. They may have worked slowly to avoid making mistakes. You know, so you might have as an adult, Casey was easily distracted is easily distracted at home and chaotic. She's untidy, there's clutter all over the house. Hopeless, she's hopeless at budgeting, and she's late wherever she goes. And she's forgetful and often loses her phone. At work, she's often stressed and anxious. She frequently leaves work to the last minute and misses deadlines. Her manager complains that she regularly makes errors and thinks this is because Casey spends a lot of time daydreaming. So these are the kind of issues that are going to come up. Again, with hyperactivity, there are 6 criteria which assess hyperactive symptoms. But in adulthood, the person, as I said earlier, is usually less hyperactive than they were as a child. But they do suffer these internal feelings of restlessness. They have difficulty settling for long periods, and they fidget or chatter inappropriately, for example, at the cinema. They find it hard to unwind and relax. They find it hard to they have to be doing things. And some people have difficulty getting to sleeping at night, because they describe this sort of, their brain, they feel it's like there's ceaseless mental activity that's going on and on all the time in their brains. I think it's worth going through these to give you an idea of what the kind of things that you might get and the prompts that you would have. So a prompt for you as a clinician is that at home the person may feel restless even when watching television, at the dinner table or in the car. They may fidget with their hands, legs and feet even when engaged on a task or activity that they find interesting, or when they feel tired. They tap pens, they're tapping. Or they fiddle with other items. They fiddle with their hair, bite their nails. Adults can control their restlessness, but they feel distressed and uncomfortable as a result. As a child, they were frequently told to stop rocking on the chair, kicking their legs and fiddling with objects. In their occupation, work colleagues may complain that the person never seems to settle and distracts them from doing their own work due to their fidgeting. They're restless in meetings. In a meeting they're very restless and fidgety. And they distract people by fiddling with items and fidgeting about. They seem to be more occupied with doodling or playing with gadgets than following the conversation. As a child, teachers commented that they were more fidgety and restless than other children in class, irrespective of the topic or activity, and that their fidgeting disturbed other children. So an example of what might be written in the boxes is Robbie's always fidgeting. He finds it really hard to sit still for long periods of time, meaning that he rarely sees the end of a film at the cinema or church service. He really enjoys more energetic activities and is a keen triathlete. But Robbie had to leave his job at the office because he couldn't stand the long hours at his desk. Similarly, the meetings were tedious and he preferred being on the go, so sometimes he would walk laps around the office in his breaks. Now, Robbie's a climbing instructor, and he enjoys that much more. So he's found an occupation that suits him better. So again, with the impulsive symptoms, it works in much the same way. With a person, your prompt would be the person struggles to following the turn-taking rules of conversation. Do you know what I mean by that? If I say hello, you'll say hello. And if I say, how are you? You'll say, I'm fine, thank you. How are you? It's a rule. It's a turn-taking rule. They seem tactless and motivated to say what's on their mind, even if this is unrelated to the topic of conversation. They complain that other people talk too slowly and they find it difficult to wait for them to finish. These behaviours negatively impact on their relationships with family, friends, peers, teachers and siblings, both in childhood and in adulthood. In their occupation, the person may appear to talk over others in meetings, so they might appear to dominate, or they seem disinterested in the perspective of others. They irritate colleagues by saying what comes to mind without considering whether this is appropriate or confidential. As a child, they didn't give others a chance to answer questions, but they blurted out answers, even if they were wrong. In both childhood and adulthood, these behaviours irritate others and may lead the person to be considered unpopular. The symptom that this is describing is, the symptom is, do you often blurt out answers before questions have been completed? So it's very specific. So an example of what might go in the boxes is, Lewis has never been good at waiting. When in the queue for the bus or the cash machine, he has to focus or he becomes irritated and frustrated. This impatience is also seen verbally as Lewis talks over his friends and finishes their sentences for them. His friends have mixed feelings towards Lewis. His colleagues have mixed feelings towards him. Some enjoy his bullish nature, but most find him intrusive as he disturbs them when they're working. He's demanding, and he's seen as attention-seeking. Lewis invades personal space and struggles to keep information private. So that's the kind of stuff that would go in there. There then follows, there isn't an observation section, but there's a section called presentation. And this is where you can make notes regarding your observations of the person, their interaction with others and their behaviour. It's just a space to put some notes for anything that you feel is pertinent that you've seen with your own eyes. And then you move on to comorbid conditions and disorders. And again, you'll make, just as before, you'll make qualitative notes in the respective box. You have to decide whether it's present, if it's a known, you say whether it's present if it's a known diagnosis, whether it's absent or possible, in which case you might need to find out more information. They're exactly the same ones as ACE. I'm not going to repeat those, but there are a few additional ones for adulthood, and these include personality disorder, bipolar disorder, psychosis, and emotional instability. The prompts for those are, is there evidence for PD, for personality disorder? Is there any evidence of social and behavioural problems that may indicate a personality disorder, such as antisocial or borderline disorders? Bipolar disorder, for that you'll consider is there evidence of an episodic disorder, including mania or hypomania? For psychosis, you'll consider is there evidence of thought disorder, delusions or hallucinations? And these are all prompts that you have in front of you to help guide you with your assessment. For emotional instability and dysregulation, you'll be thinking, is there any evidence of changeable and volatile mood, including anger, frustration and irritability? Again, you'll have two different scoring criteria depending on which one that you are using. For DSM, you have to, of course, now because you don't wake up with ADHD as an adult. You've got to go through. You've done the assessment for their childhood as well. So you rate for childhood in the same way that you've done ACE, and then you do a similar rating for using DSM criteria for ADHD in adulthood. And again, you have the prompts that are about comorbidity and impairment, etc., and pervasiveness. Same for ICD-10. First of all, same as ACE, the three symptoms separated out plus the pervasive impairment and comorbid problems, and then the same for adults. So this is where you can get it. This is the website, psychology-services.uk.com. I have a lot of resources that I put on there. They're all free to download, mainly in English though. But as I said, ACE and ACE Plus is in Turkish. But, I hope you use it and I hope you find it helpful. ADHD can be diagnosed. There are clear, diagnosable clinical criteria. It's very clear. It's very well described. We usually use DSM-5 because this allows for more flexibility, allows for comorbidity. If you use ICD-10, that's going to diagnose a more severe form of ADHD known as hyperkinesis. But ICD-10 is being updated, and we anticipate that that will be out, is it next year, I think. Both ACE and ACE Plus are available in Turkish, and it has the semi-structured interview to prompt you for comorbid conditions. And there's no others, I think, are doing that. The big thing by doing that, though, it helps you to consider the needs of the individual. What is that person? It's not just a person isn't just an ADHD person. A person has difficulties and problems, and what are their needs? And so it's about, that then in turn will prompt you to think about how do you address those needs? How do you treat those needs? What support and help do they need? We know that there are good medications for ADHD with a good treatment effect, but sometimes, they need, if there's a lot of other stuff going on, you need to have perhaps some psychological input as well. Well, I'm going to stop there. I've been talking a lot. I need to have some water. But thank you very much for your attention, and I would really love to get any feedback that you have from ACE, if you use it, or ACE Plus. You can see that it will lend itself very nicely to an electronic version, and fingers crossed we might be having one soon that can be done on a computer, so it will all do all the calculations for you. Thank you.